This is On Becoming a Healer with Saul Weiner and Stefan Kertész, two physicians reflecting on how better self-knowledge makes us more effective in medical practice and education, and is essential to joy in being doctors. We do this by telling a story and reflecting on themes of judgmentalism, engagement, boundary clarity, ego, and caring. Saul is also the author of a new book, On Becoming a Healer, The Journey from Patient Care to Caring About Your Patients. Hi, Saul.
Hi, Stefan.
So, Saul, what are we talking about today?
Well, I'd like to share with you a case actually that goes way back. It has to do with a patient I took care of when I was a resident in the mid-1990s, but it had such a lasting effect. It shaped so much of how I think about being a doctor, and I think it has so many lessons embedded in it that I thought it would be useful to share today.
Well, what happened with the patient?
So I call him Arthur. I think I was a second-year resident. I was a junior resident at the time, and on the inpatient unit, this was actually, I think, general medicine. We had a lot of sickle cell patients at the time. I did my residency in a hospital on the south side of Chicago, where there was a large African American community, and as you know, sickle cell disease is prominent among certain genetic groups, including certain Middle Eastern communities, African American communities, and so forth. So we saw quite a lot of sickle cell disease, and a lot of these patients would have frequent sickle cell crises. They would come in with a lot of pain, and often they were on high doses of narcotics. And there was frequently a kind of contentious relationship between the doctor and the patient over their demands for narcotics, as we saw it. And this could really kind of wreak havoc with the doctor-patient relationship. Arthur was one of those patients, and I actually was warned before I went in to meet him that he was, quote, a difficult patient, and that he could be really demanding, and manipulative was the term that was used. And he was also labeled as non-compliant. People referred to him as a non-compliant patient. So I walked in to see Arthur and kind of ready for the worst. And to my surprise, he was actually friendly. He was friendly. He made good eye contact. We had a normal conversation. And
did you feel you had to prepare for your visit with Arthur?
Quite honestly, I was sort of eager to impress him.
Are you saying you prepared for the visit?
I wanted to make sure he knew that I had done my homework. I'd looked closely at his chart because I just had this intuitive sense that I was being tested. And I had already kind of decided that I was going to relate to him in a way that I thought was different from the way other doctors often did. I was going to, I guess you could say, lean in and try to form a relationship with him. And I also knew that there was probably going to be some pushback. So I wasn't quite sure how it was going to go, but I knew that I wanted to try to make things be different this time. So one of the things that was important to me was to be prepared to be tested. And so that if he started throwing curveballs at me, I would know my stuff, know what was going on with him and so forth. So that was why I think I was extra prepared. But again, as I said, he was bright, he was very friendly, and we were off to a good start.
What happened next?
Perhaps not surprisingly, he started asking for me to increase his Demerol, which at the time was a medication that was very common among patients with sickle cell disease. There was often this dynamic where they wanted Demerol and we wanted to switch them to morphine because the view was that Demerol can cause seizures and that it was considered to be relatively short-acting and potentially addictive, and it caused euphoria. And for all those reasons, we were often in this type of dynamic where we wanted to get patients off of their Demerol and onto morphine. And so...
Should I interject on the opioid aspect?
Please do.
Just to acknowledge that the pattern of patients who often presented to emergency rooms seeking Demerol, which is a commercial name for meperidine, was pretty typical. The seizure risk is real. It's short-acting, and so there's at least a possibility that there could be a different kind of addictive potential, although it's never been totally figured out. But I think we can say comfortably that the situation of patients asking for that has been provocative to doctors for at least 20 years.
Sure. And at the time, we saw a lot of that type of a dynamic. Well, sure enough, even before I got out of the room from the first visit, he was asking for me to renew his Demerol before he went home. And one of the things I'd heard is that he would leave AMA as soon as I gave him Demerol. And I said, well, I wasn't comfortable doing that. I wanted to go with switching him to morphine. And this was after we'd had a fairly pleasant conversation. And I thought we were building a bit of rapport, but he immediately started to get hostile and said that, well, if I wasn't going to do that, he didn't really have any need for me.
Wow. So then what happened?
I was hoping that he would come to clinic. We'd already talked about that he was going to follow up with me. And while he had started out seeming really positive about it, all of a sudden he was kind of telling me that I was a terrible doctor, that he didn't have any need for me, that I wasn't listening. And what was going through my head at the time was, I understand this is kind of his drill. This is the dynamic that I've heard a lot about, and I need to figure out a way to get past this. So I said to him, I really hope you come to my clinic. I would love to see you. And again, the response was, well, I need the Demerol. And I said, look, Arthur, I'm not comfortable giving you the Demerol.
What was his reaction?
He said, well, don't you believe me that it works better than the morphine? The morphine does nothing for me. And I said to him, well, I don't really know you, Arthur, but I can tell you that I'm personally not comfortable giving you this medication because I know it could cause seizures. And I'm not willing to take that chance.
Then what happened?
So he said, well, I'll think about it. Maybe I'll come to your clinic. So at the end, he left with a prescription for morphine. And I kind of knew he probably wasn't going to show up for the appointment. And sure enough, he didn't. What
was your reaction?
I waited till clinic was over that afternoon after I'd seen my other patients. And then I called him. I called him at home. And I said, Arthur, I missed you today. I was hoping you would come in. And I think he was a little surprised that I called him, because my sense was that he was used to doctors wanting to get rid of him. And so the call, I think, was a bit of a surprise. He actually said that he was busy babysitting his niece and nephew, and so he couldn't make it to the appointment. And I thought maybe he was making that up, but I actually heard them in the background. So we chatted about that. I learned a little about his nieces and nephews, and I said, let me reschedule you. And he said, okay. So rescheduled. And then sure enough, he didn't come in again. One of the things I learned looking at his chart was that he had started to develop hemochromatosis from many blood transfusions. As you probably know, patients who have sickle cell disease often end up needing transfusions, and they're at risk of getting iron overload. And over a number of years, in fact, he had been advised to get chelation therapy.
What's that?
Chelation therapy it's an approach to binding the iron that's floating around in the blood. They use desferoxamine. And apparently, if you start doing that early enough, particularly when you're doing a lot of blood transfusions, you can just prevent hemochromatosis, can mitigate it substantially. And if you don't do that, then the iron starts to build up in the liver and then eventually in the heart, and it's just irreversible. And one of the things about chelation therapy is it requires getting this medication intravenously for 8 hours. Typically, it's done during the night. So it requires a fair amount of patient cooperation. And he was just considered non-compliant and not reliable, and so he just didn't get it. I saw this, and I started reading up about it, and I realized that this was critical. And so when I spoke with him, I told him that it was really important we got him onto this. This was during the second call after he'd missed the appointment the second time. And the second time...
he had 2 misses? He missed your appointment twice and you called him twice?
I called him twice. And so what happened is the second time, he didn't really have an excuse. There was no niece or nephew in the background. And, he said he forgot. And I said to him, Arthur, you're too damn smart to forget. Like, you didn't forget. And...
What was his reaction?
I think he was... he didn't say anything, but I think he was probably a little pleased that I recognized that he was bright. But he was genuinely, I think, more friendly, particularly given that I had now called him twice. And when I brought up this issue of desferoxamine with him, I said he needed to see a hematologist, and I set up a visit for him. So he said he would go to that visit. And then, sure enough, on the day of the visit, I called him and he had not gone. And so we had another conversation, and I scheduled the visit for him a second time and another visit with me. And on the second attempt, he actually did go. He went to see this hematologist. And then from then on, he never missed an appointment with me. And he got on to this desferoxamine therapy. Involved setting up a VNA, a visiting nurse who came to the home. We also got him on hydroxyurea, which reduces the frequency of sickle cell crises. So we got him on 2 medications. But the desferoxamine was the one that was really important because of its chelation potential.
How did that play out for him?
One of the things, unfortunately, that I learned from the hematologist was that he had advanced hemochromatosis at that point. His liver was cirrhotic, and there was some concern that it had affected his heart already. And he was starting to develop some symptoms of heart failure from the advanced effect of the hemochromatosis on the myocardium. And, Arthur was only 26 years old. And one of the things that started to come out during our conversations was that he had become quite weak. He joked about the fact that he didn't hang out with the gangbangers anymore because he was an old man. And yet I got the sense that he understood that this might not be something that he was going to survive.
Oh.
There were periods during those later months where he would regress in his relationship with me, and all of a sudden, out of nowhere, it was almost like throwing a temper tantrum. He'd start to demand Demerol again. But one of the things that I came to appreciate was that it was sort of a different dynamic. He just needed somebody to vent to, and I think he trusted that I wasn't going to abandon him, even if he went rogue and started attacking me for not giving him Demerol. So even though I found it hurtful, he would say things like, well, I have no use for you if you're not going to give me Demerol. And this was after we'd become quite close. I realized that this was something that I just had to ride out. And I would say to him each time, tell me what's going on with you. And eventually we started talking about the fact that he might not make it. And it was clear to me that he was really intelligent because he figured this out. I hadn't told him that this might be a fatal condition, that his days might be numbered.
Then what happened?
I didn't realize how numbered they were until I got a call from a visiting nurse saying that he had died.
Oh.
He had died one night while he was getting his chelation therapy. And it turned out that it was basically an arrhythmia. And one of the things I learned is that people who have advanced myocardial injury from this particular condition, often the final event is often an arrhythmia. So I called his mother, and she told me about the funeral. I wanted to find out when there would be a funeral. He lived in the Auburn-Gresham neighborhood of Chicago on the south side. And then on the day of the funeral, I went over there.
So you went to the funeral. What was that like?
One of the things that I remember is getting out of my car and realizing that I was the only white guy around. And it was just a strange feeling for me.
So was he African-American?
He was African-American, yeah.
Yeah.
Yeah, he was black, and I realized I was the only white guy, and I got out. It was this big parking lot in front of a funeral home. But I also noticed that no one was looking at me funny. Like, I realized that I was feeling uncomfortable, but no one looked at me strange. And when I headed into the first hall you walk into when you go through the main door, immediately somebody found me and took me over to greet his mother, where I was able to offer her my condolences. As the funeral was about to start and everybody was going into the chapel, I was planning to sit in the back, but an usher came over to me and said, Ms. Barnes, that was her name. Well, that's not a real name. I think that's the name I've given her. Ms. Barnes would like you to sit with her in the front.
What was your reaction?
I felt very awkward about that. I didn't feel like I deserved to sit in the front next to Arthur's mother, but I also realized that that was what was expected of me. And so I went all the way up to the front with everybody doing their thing. I didn't feel like anyone looked at me funny. I sat next to her and I could see Arthur. His casket was open. I got to see him one last time. And that was the end of the story for me and Arthur. I did call his mom periodically over the coming year to see how she was doing. Let me pause there. I think there's some really important lessons here that have stuck with me, but I want to see whether you have questions before I kind of delve into them.
So, yeah, I do. I have a couple. So, first of all, I think it's relevant here. This whole story takes place on the south side of Chicago. You're white, he's black, he's poor too. And that must have been a pretty typical part of your training. Is that right?
Yeah, I took care of a lot of patients who were black simply because of where I trained.
Who were poor and black.
I should say who were poor and black.
Got it. When people felt that he was hostile or manipulative, is it really all just based on his saying that he needed to get that one drug, Demerol?
Well, that's a really important question. I don't know. It's very hard for me to delve into the minds of my colleagues. If he had been a white middle-class guy, would they have looked at it that way, or would they have said instead, this is somebody who's in a lot of pain because they have a serious condition? In other words, would they have cut him a lot of slack if he had looked different and was from a different socioeconomic status? And I can't help but thinking the answer to that is yes. And we know that if you go back 100 years, we know, for instance, that the likelihood that people would get even anesthesia was related to their social class and their color.
So there's some of that going on. But nonetheless, I can say, having observed many doctors, that when patients speak consistently about opioid pain medicine, that it does cause a reaction very often. And the reaction is one where inevitably the clinic team or the doctor or the nurse begins to feel like something is amiss or awry or something could go wrong. And I would guess it's probably a sense of, we are the clinicians, you are not supposed to control us. We are not a candy machine. And I want to ask you, is there something wrong with clinicians feeling that they should not be controlled by patients, or for a clinician to say, I'm not a medication dispenser?
Well, as you know, my book deals with a concept called boundary clarity quite extensively. And I really think it's important here to talk about how boundary clarity is a general framework for thinking about the question you just asked. Boundary clarity is the ability to distinguish clearly between what is going on inside you and what is happening in the moment with the patient. And so when you get defensive because you feel like the patient is trying to control you or manipulate you or anything along those lines, there's a breakdown in boundary clarity. Because you're focusing on, because you're becoming indignant, because you're feeling like there are emotions inside of you that you're not happy with, you're preoccupied with those instead of thinking about what might be going on with this patient. And what might be going on with the patient is any number of things. I surmised that with Arthur, particularly based on what I learned after getting to know him, that he felt helpless. You know, he was frail. He had no control over what would happen to him when he came in the hospital. He was in pain. And his one way of coping with it was basically trying to exercise some control over his physicians and other caregivers. And so the dynamic was really about Arthur's need for control and also a desire to test the people around him to see if he could trust anyone. And because the physicians were so preoccupied with the emotion that it elicited in them, they were unable to think about what was going on with Arthur as data. And that loss or that lack of boundary clarity, I think, was ultimately catastrophic because it disabled them from forming a therapeutic relationship with him. It disabled them from forming a partnership where they ultimately could get him on a medication that could save his life weeks or months or years earlier, which ultimately led to his untimely death.
So this is key, and we need to linger for a second, that if I am mostly focused on the question of control, then, and that I fear I am going to be controlled by a patient, which is what I think is going on here, then I might not, first, that might not be realistic. The truth is, in the end, the patient cannot control me. But second, I might miss something else about the person that I'm trying to form a relationship with. Is that fair to say?
Yes. And I think another thing that's critical here is it's not just a question of having boundary clarity in your head. It's a question of knowing what to do when somebody is trying to penetrate those boundaries. So there's no question that Arthur was trying to mess with his doctors. And so in this particular situation, he got labeled as manipulative and difficult. I think if a doctor has boundary clarity, they're actually able to do two things. One is they're able to recognize the emotions that are being essentially triggered inside themselves and not to react to those emotions. That's number one. Number two, they're able to respond effectively to what's happening with the patient by being clear to the patient that they're going to protect their own boundaries. So in this case, when Arthur said to me, "So you don't want to give me Demerol, yet you think that I'm telling the truth. How can that be? If you trusted me, you would listen to me." This was the kind of dynamic I was getting into with him. With other doctors, they would kind of have to wrap themselves into pretzels to explain why, on the one hand, they didn't distrust him, but on the other hand, they weren't going to do what he said. And then he would point out their inconsistencies. In fact, what was needed here was for the doctor to simply be straight. And what I said to him is, "Look, buddy, I don't know you. I have no idea if I can trust you. I can tell you I'm not going to give you this medication because I don't think it's safe. I don't want you to get seizures. I know you may want it, but it's not something I'm going to take a chance on with my license." And I'm not clear why doctors were unwilling to be open with him about the fact that they didn't trust him. But I think it had to do with the fact that they were unclear about their boundaries, and so they just didn't know how to respond to him. He sensed that. He went for the jugular, but ultimately it was sort of self-destructive because he would be driving these people away and ultimately not getting the care he needs. But they're the ones who are responsible for making sure that ultimately the relationship is therapeutic and in his best interest. So I would have to say the final lesson here is that they failed him.
Yeah. I mean, the key, and just in case it isn't crystal clear, because the jockeying relationship and the reactions always were about Arthur seen as a manipulator, the options of taking all that iron out of his blood or getting on hydroxyurea, those options were set to the side for years. And the result was Arthur's early death.
Exactly. And I think it had to do with the fact that so many doctors did not have clarity about boundaries. As a result, they were not able to engage with him. They weren't able to have a genuine relationship. And that resulted in him being labeled and him not getting care that he needed when he needed it. And so that is a competency, the capacity to know who you are, to be clear about your boundaries, and to know how to respond to a patient who is attempting to push those boundaries without holding them at a distance. That's a competency. It's a competency that his physicians didn't have. And I think it's so important because when we talk about competencies in medicine, we typically talk about biomedical competencies. Do you know how to treat this? Do you know how to do this procedures? But I think the capacity to know your boundaries, to be clear about them, and to know how to engage in situations like this is a fundamental competency that isn't really characterized and talked about enough. And if you don't have it, people die.
I wonder if you'd let me offer a couple thoughts on this case and then give you the last word.
Sure.
So the first thing that resonates to me in this story is the idea that there was a long-term stalemate between Arthur and his clinicians. And the stalemate was built around the routine move that he used with his clinicians, which from his perspective was to get his needs met, but also was a way of testing and messing with the clinicians to see if they were direct. And one of the helpful things you did was to declare what you could and could not do, which is honest. So he could know right away that you weren't dishonest. But you also did it sounds like, without anger and without being particularly afraid that things were going to fall apart. So you didn't need to be angry and vindictive in your stating what your limitations were. You just said, this is what I know now. And I feel like that happens for me too. Sometimes patients are discussing issues related to opioids with me, and I say, this is where I'm at. This is what my understanding is. These are some of the rules that I'm thinking about that were in terms of how people look at what I do. And so this is what I think I can do today while I try to sort this out with you. Can you give me some time so that we can figure the steps out? And when people see that I've set a limit, but that I'm actually not particularly uncomfortable and ready to work with them, they usually give me quite a bit of leeway to continue to work with them. So not letting the emotions of the moment that you feel internally drive your next move seems really, really key. And that's probably what I get out of this. Do you want to have the last word, Saul?
Yeah, I think that what was missing with Arthur and all of his doctors, and I think you said it well here, but people often talk about the importance of a therapeutic relationship, which they were unable to form with him. And I think they blame that on him rather than recognizing that they had profound limitations. I prefer the term an engaged interaction over the term a therapeutic relationship because therapeutic relationship sounds a little bit sterile to me. I think of an engaged interaction as a truly human interaction that isn't just doctor in a white coat with patient in a bed. It's a relationship between two people, one of whom happens to be a patient and the other who happens to be a doctor at the time. But it's a true human relationship. And I think that is fundamental. Now, I'm not going to argue that can always happen between any doctor and any patient, but clearly it was possible with Arthur. It was something that I greatly enjoyed and found deeply nourishing, but I don't think it was something that was uniquely only possible between me and him. I think that his prior physicians fell short because they were so threatened. They lack clarity about their own boundaries. They didn't know how to deal with somebody who was poking at them, and so they constantly pushed him away. It was a dynamic that he instigated because he needed some sense of control. He had a profound lack of trust, but they lacked the competencies to respond effectively, and ultimately that was to his detriment. I think the take-home message here is when we think about training physicians, when we think about becoming competent as physicians ourselves, we have to go beyond, do we know the biomedical stuff, to do we know how to form effective relationships with patients around issues where a clear sense of boundaries and a capacity to engage are paramount, and when doing so can be life-saving and certainly is essential in a wide variety of relationships between doctor and patient.
Thank you so much, Saul.
Thank you.